So good day, everybody. I'm Dr. Polite. I am a professor of medicine at the University of Chicago, where I specialize in the treatment of gastrointestinal tumors, and in particular with neuroendocrine tumors. So I want to thank you all so much for being here with us virtually. New experience for everybody in 2020. So again, thank you for being here, and I'm excited to be invited back. So today I've been given the charge of talking a little bit about sort of the more future-looking therapies in neuroendocrine tumors, some of which we're using already, some of which we're exploring, but again, beginning to explore what the horizon looks like. So it's important for me to lay a little bit of groundwork. Again, I don't want to cover territory that's already been covered, but just to make sure we know what we're talking about as we discuss the classification and particularly the grading of neuroendocrine tumors. And then, set again the groundwork for some of the current therapy options, just to understand, what bar it is that we're looking at in terms of newer therapies and new improvements. And then obviously spend the bulk of our time on discussing some of these more future-looking therapies. So again, let's begin with understanding what we're talking about in terms of neuroendocrine tumors, because the terminology around this is very confusing to even seasoned oncologists and pathologists. And so I can imagine it's also very confusing to a lot of patients out there. But we have three different varieties of what are well-differentiated tumors. And those include those that are low grade, intermediate grade, and high grade. So this creates, again, a great deal of confusion because you can have a tumor that is called high grade, and grade is based on the mitotic activity. So how much movement and replication we're starting to see in the cells, but that can look very good under the microscope. And so you can have a high grade, well-differentiated tumor. So this sounds like a oxymoron to most people who work in this field, but indeed you can. And so that's going to be important when I talk about a well-differentiated tumor. I may very well mean something that's grade 1, but I could also mean something that's grade 3. So it's important to keep that in mind. And then we'll also be talking about more poorly differentiated tumors, which have a sort of very different flavor and subset to them. So one of the areas that have been successful really across the board in neuroendocrine tumors, and by what I mean by across the board is in the GI world, these days we tend to pretty much simplify the neuroendocrine tumor world into pancreatic and to non-pancreatic neuroendocrine tumors. But in those settings, we're starting to see activity for so-called Antivegf, so that's the vascular endothelial growth factor, but essentially drugs that target these receptors. And these receptors are ones that eventually control for migration of tumors, for survival of tumors, for bringing in new blood supply. So you will obviously see a lot of therapies that are in this category. Then we have a new set of drugs that for lack of a better term, we tend to call them promiscuous tyrosine kinase inhibitors or multi-targeted tyrosine kinase inhibitors, ones that target not only things like VEGF, but target other critical pathways, things like MET and AXL and others. Again, the importance of these is they're all different ways that both blood vessels respond to cancers and the way tumor cells respond to stimuli that come in from the blood. And so the idea is to be able to block these. So one of these is a drug called cabozantinib, and we'll be talking a little bit about cabozantinib today. And finally, another class of drugs that people are very familiar with are the so-called MTOR inhibitors. Everolimus being the one that most people have heard of, Afinitor being its trade name. But we have known for a long time that MTOR inhibitors have a critical role in the pathway of neuroendocrine tumors, which are often driven by insulin growth factor receptor that are highly expressed on neuroendocrine cells. So that's the biology. Now, having said that, any oncologist worth their weight or a pathologist worth their weight in anything will tell you that we really don't understand how the cell actually works. So we like to draw cartoons for you and show you these very nice pathways, but indeed the cell signaling mechanism probably looks a lot more like this. where there are just a lot of things going in a lot of different directions. And this makes it challenging for us to really design therapies and understand why some therapies work and some therapies do not. So again, just setting the stage for what I think is arguably, the most impressive outcome we have seen in neuroendocrine tumors from the NETRF trial. Again, using peptide radionuclear therapy, receptor therapy, where we have seen very, impressive increases in progression-free and, overall, and suggestions of improvements in overall survival. With, some degree of response rates, but, median progression-free survivals in the 30 plus month range. And so as we try to develop new therapies, you have to sort of look at your existing ones and say, can I do better than this? Or what do I do after this no longer succeeds? And I think that is a lot of the way we think about and begin to frame our discussions. So, a reminder that all patients that have well-differentiated grade 1 and grade 2 are in the inclusion, are considered candidates for lutetium-177, Lutathera therapy. And there's continuing data that is suggesting that the grade 3 neuroendocrine tumors that have uptake on the so-called dotatate PET scans, so the PET scan is very specific for these tracer molecules, also have activity. So in our practice, we consider grade 3 NETs that are well differentiated certainly candidates. Often your poorly differentiated NETs tend not to have a lot of uptake, not across the board, but usually don't have great uptake on these scans. Kidney function and bone marrow reserve are very important. Again, there's work being done of how can you dose this better in patients with some degrees of renal insufficiency, but those should only be done under pretty controlled settings because obviously you can run into very significant bone marrow toxicity if we're not careful here. So chemotherapy has, had its life in neuroendocrine tumors very early on. A lot of our predecessors, even some people in the room, probably used a fair amount of drugs like streptozocin. I, for one, who have been doing GI oncology for over 20 years now, have never prescribed streptozocin. But if you go back to the 80s, there was evidence of those type of therapies working in neuroendocrine tumors. Then, chemotherapy, I think, fell along the wayside, except that we were seeing very small case series using capecitabine and temozolomide, and had presentations like the ones here showing just these dramatic responses where you have a liver full of tumor and, they get this drug and this combination of drugs, and all of a sudden, tumors seem to disappear. But the criticism was always very small trials, 15 patients, 20 patients, retrospective data. So an important trial that I think all of us are waiting to see finally published was presented at the ASCO meeting a couple years ago. This is the so-called Econ 2211 trial, which is fairly large in neuroendocrine world, randomized phase 2 trial, and essentially asking the question of using the alkylating drug temozolomide or using that drug in combination with the oral 5-FU derivative capecitabine. And fairly standard randomized trial to these drugs, given over 14 days, and then people have 2 weeks off, so it's on a every 28-day basis. And importantly, what we saw here, and I think what impressed people the most, was this median progression-free survival in the 22 to 23 months range. So again, it's not Lutathera level where we're seeing over 30 plus months, but very, very impressive with the addition of capecitabine and temozolomide in terms of progression-free survival. So again, people getting these drugs for 6 months to a year, half the patients were going nearly 2 years without their tumors growing. So this is something I think is, very important part of our armamentarium. And the other nice thing that we've seen is responses, right? So we're seeing response rates. Some of the earlier trials gave us a lot of hope that response rates may be 50%, 60%. Now you see in a slightly larger trial, the number looks more like 30%, 35%, but still in patients where we really need tumors to shrink, and we need them to shrink quickly. Many of us, prefer this regimen. And the important caveat here is that this therapy appears to work mainly, if not almost exclusively, in pancreatic neuroendocrine tumors. There are some data suggesting some response rates in non-pancreatic, but certainly it is not as dramatic as we see with neuroendocrine tumors that are of pancreatic origin. So this is a go-to regimen for many of us when we really are looking for response in neuroendocrine tumors. And for the most part, fairly well tolerated therapy. Another, therapy that if you go to experts in neuroendocrine tumors, we will often pull out of our back pocket is a combination of 5-fluorouracil and oxaliplatin, so-called Fullfox. If we use it with the oral 5-FU drug, we call it Kpox. This is well known to GI oncologists as it has activity in most of our cancers, stomach cancer and colon cancer being, the most predominant. And the data for neuroendocrine tumors is not robust. It's small numbers of patients, but you can see that in some patients, especially pancreatic neuroendocrine patients, perhaps we're seeing response rates again in the 35 to 40% range. So this is a therapy we consider, especially for some of our poorly differentiated neuroendocrine tumors that have Ki67s that aren't quite small cells, so they're not 70%, 80% turnover, but are more, in the 25-30% range, or for patients where capecitabine and temozolomide don't work, we will consider 5-FU and oxaliplatin-based therapy. So again, it's something else that's in our arsenal, although, again, I wouldn't say it's supported by the strongest of clinical trial, what we would call level 1 evidence. So I mentioned before cabozantinib, this VEGF and Met inhibitor. There's a lot of interest in these drugs. So these are, if you know the drug sunitinib or Sutent, these essentially are next generation versions of that drug. And we have preliminary data, showing nice response rates and, again, very long progression-free survivals with these drugs. There's another drug called levantinib that in the phase 2 TALENT trial for pancreatic neuroendocrine tumors, again, we saw response rates in the 40+% range, which is more than we typically see with drugs like Sutent or Afinitor. And again, progression-free survivals in the, a year and a half, 2-year range. So, keep a close eye on this space for these new second, third generation VEGF and multi-tyrosine kinase inhibitors. And in particular, I really encourage folks to support and consider the ongoing Cabinet trial, which is for patients with advanced, again, primarily non-pancreatic neuroendocrine tumors whose tumor has progressed on everolimus. And they're randomized to cabozantinib or placebo. So again, I think this will be an important trial showing the role of VEGF, and in particular, this generation of VEGF inhibitors. And again, I think the space is mainly in the non-pancreatic neuroendocrine tumors. So again, this is an ongoing trial, and we encourage participation. You can't give a talk in cancer these days without discussing immunotherapy. So there's a great deal of excitement about immunotherapy through a variety of cancers. In the GI world, I will say that we have had less success. Gastric cancer probably being the one that is furthest along. Colon cancer, we can see very dramatic responses in a very small subset of our patients. So it is no surprise that immunotherapy is being tried in neuroendocrine tumors. And what I will say is, for low-grade tumors, for most of your well-differentiated low-grade tumors, immunotherapy by itself, so traditional single-agent immunotherapy, is not likely to be our answer. So here are a few trials I will show you. We'll focus a little bit more on the Keynote 158 trial, but there is a newer drug, spartalizumab, which again is a so-called PD-1 IV therapy. Saw pretty dramatic responses in thoracic neuroendocrine tumors, but if you looked at the pancreatic neuroendocrine tumors, very low response rates. Pembrolizumab, same thing, very low response rates, very sort of, unimpressive progression-free survival of only 4 months. So again, I will emphasize the point that I don't think single agent version of these is going to be the way to go. But there's been a lot of interesting work we see, particularly in hepatocellular cancer, where combinations of VEGF inhibitors, in that case, bevacizumab, but you can imagine, again, some of our tyrosine kinase inhibitors combined with immunotherapy is having some effectiveness. So, hold tight on different ways for immunotherapy to be incorporated here. But again, I think single agent won't work. Just to show you a little bit more, detail. So this was the Keynote 158 trial, which again looked at the PD-1 inhibitor pembrolizumab, and patients were treated with this. And what these curves show is, first of all, very few patients actually had responses. So you had a couple patients who had responses. We're not quite sure why they responded. There's one of them who has an ongoing response, but again, it is incumbent upon us to start figuring out who these patients are. But what's interesting is one of the ways that we think we can predict who's going to respond is by looking at whether or not the tumor cells or the immunotherapy or the immune cells surrounding the tumor express this thing that's being targeted by the drug, so PD-1 and PD-L1. And interestingly, it turns out, going back to we don't really understand how the cell works, most of the responses that we saw in this trial were with patients who did not have any staining for these receptors. So again, those are the folks that you would expect not to respond, and some of them did respond. So just shows you we have a long way to go. And the curves below here, again, showing this is progression-free survival, that most patients simply did not benefit from this therapy. On the other hand, a very exciting trial that is important, I think, for everyone to have on their radar came out of the so-called DART trial. So the DART trial is a large multi-tumor trial being run by the Southwest Oncology Group in conjunction with the National Cancer Institute. And essentially they were looking at combinations of immunotherapies, so-called anti-CTLA-4 drugs, as well as anti-PD-1 drugs in rare tumors. And so one of the rare tumors they were looking at were neuroendocrine tumors. And what this chart here shows you is that in patients, especially with high-grade neuroendocrine tumors, you were seeing response rates of up to 44%, and including many of those with, long-term responses. This right set of plots that we call swimmer plots show you that in red, it tended to mainly benefit the patients with high-grade disease. And that there are a number of patients who not only responded, but continue to respond. And that's, of course, the dream and the grail that we see with immunotherapy is that if patients respond, the responses tend to be durable, sometimes many, many years. And in melanoma, we're seeing people 5, 6, 7, 8 years out with metastatic disease, who haven't been on therapy for 5 or 6 years and continue to respond because the immune system does its job. So I think for the high-grade neuroendocrine tumors, this is a combination that looks to have activity, and I think is something that should be, in our arsenal for patients. So let me just give you my, sort of bigger sum up. Not all this data I presented here, but sort of in general, how I think about neuroendocrine tumors. Again, for my patients without any major symptoms, I'm still a strong believer of observation. No need to put people on therapy for tumors that can be indolent and some that won't grow for a year and a half or 2 years. For growing tumors or symptoms, obviously the somatostatin analogs, octreotide, lanreotide, are all reasonable choices. Rapidly growing tumors, definitely for the pancreatic neuroendocrine tumors, I like capecitabine and temozolomide. I think Fullfox or Capox, Xelox are all sort of options, but I think probably the ipilimumab, nivolumab, which is the combination that was used in the DART trial, is one that is moving earlier in my armamentarium. Again, I'm probably capecitabine, temozolomide first, with ipi-nivo second, but that can change over time as we get more evidence and we get more comfort using these. Obviously, slowly growing tumors, lutetium or sunitinib or everolimus are all possibilities. And then I know that's going to be presented here. You're going to hear a lot of talk on patients with liver-only disease. I think a lot of exciting work being done by some fantastic surgeons around the country, both in areas of doing, significant debulking in patients that we believe we can get, about 90% of the tumor debulked from the liver. There seems to be survival advantage there. And there's a lot of interest on the transplant side now, and a lot of work being done on transplant for neuroendocrine tumors, primarily because the concern had always been, if you essentially suppress the immune system after a transplant, you have very high risk for tumors coming back, and that remains so. However, with the ability to use MTOR, so drugs like Afinitor, as our immunosuppression that also has anti-tumor activity, there is some hope that we can at least blunt the effect of the immune suppression, on the recurrence of these cancers. So with that, I thank you very much for your time. I look forward to whatever panel discussions we're going to have here virtually, and to answer, many of your questions. And I think there were a lot of questions that I saw, looking at the immunotherapy. People talked about oncolytic therapy and viral therapy. All of these are different ways to how do you stimulate the immune system and get it to target the cancer. So obviously this remains an area of intense interest, but at least we have some proof of principle with the higher grade tumors that immunotherapy can have activity. And so it's just a matter of finding the right combinations and the right way to stimulate the immune system to really recognize the lower grade neuroendocrine tumors. So again, thank you so much for your time.